Linda and I are co-presenting today. My name is Kelly Walgass, and I'm an assistant professor at Vanderbilt University School of Nursing and the program director for our healthcare leadership program. Linda, of course, is the case manager at the Pediatric Primary Care Clinic over at Children's here at Vanderbilt. And we are delighted to be with you here today. We are going to tag team a presentation for the next 45 minutes on how we have really operationalized a lot of the GOT transition initiatives. Dr. Cooley really introduced this very well in the past hour. He said to get started, and so we got started about 6 years ago. And so this has been a growing process, and we wanted to share with you where we are, how we got to where we're at, and some of the tools that we're using here at Vanderbilt at the pediatric, well, in children's and with the adult hospital as well for transition care. So you see on the slide here, this is a picture of Children's, the front door of Children's, pretty large facility. We have the benefit of living in the Nashville area, a pretty mature healthcare area here, but we still have a population of special healthcare kids who they were lost to transition afterwards. And it was a really serious growing problem. And I'm going to credit Linda and the team over at Children's for recognizing that because even in a big city like Nashville, there's not that maturity of transition processes. And so I wasn't even here in 2009. Linda and her team was. But when I came in 2011, I was talking to her and I said, if Vanderbilt can't do this, then how can we expect anyone else here in Tennessee to be able to do that? You know, some of these really mature healthcare systems have struggles with this. It is definitely hard to do out in our rural areas, our smaller hospital systems and our practices that are not as well resourced as some of the systems. And so we tried to tackle this. Here's the objectives of our presentation. You all have our slides, so I'm not going to review them, but really to tell you a little bit more about the how-to and give you some hints and to give you some resources. We want to be here to communicate with you in the future. We're going to give you our emails. If you want to converse and collaborate in the future, we're happy to do that as well. We spent a lot of time on the GOT Transition website. We've read a lot of the materials. We used all the reports that Dr. Cooley referred to in his presentation for our projects and for our process as well. Great references, and really what the nation is using, so it's tremendous. We're going to talk a little bit about the origin of our program, the reason, which I just explained, I think. We're going to really talk about case management and how we operationalize that at Vanderbilt, and having the person in the seat doing that day in and day out. One person, I'm always amazed that there's in our system, we had one case manager trying to manage a panel of special healthcare needs that was really at least 300, probably more, because we didn't really have a great way of putting them in a registry when we started this all. We're much better at that now. But having one person trying to kind of navigate that and helping all the providers in the system try to, anticipate the needs for that care population. I constantly am amazed at what Linda does each and every day. We're going to show you some process and tools. She's going to share near the end of our presentation a little bit of our outcomes. We have transitioned patients. We're fortunate to have a federally qualified health center here in Nashville that is our partner in this. They were willing and ready to take on this type of complex patient, so we are fortunate. We'll share that with you. And then we'll have a little bit of some question and answer period. So 17%, the data shows 17% of children here in Tennessee have special health care needs. I mean, a huge number. We looked at the national data, we pared it down to Tennessee. We could pretty much even tell you by county how this is happening here in Tennessee. The data can show us that. So we knew we had that. Being a tertiary care and academic medical center here in Nashville, obviously we draw a lot of that population to Nashville and to the providers that we have here. Let me just start by saying, we've got this primary care model here, which is great, but a lot of these kiddos are seeing the specialty care as well. So there was that interaction with some of these specialty clinics that were either at the pediatric level, or we do have an adult, in the adult side, some of the specialty clinics that will take the kids as they transition. So it wasn't a standard process across the board. Some of our adult clinics wouldn't take the kids right away. And so that was a communication. If you've seen Vanderbilt, you know that it's not one building, it's a big system. And just to kind of get all those people, I think as Dr. Cooley said, to get everybody at the table to talk about this was really a challenge to do. I mean, it takes effort and work to do that. We knew we weren't positioned real well back in 2009 to transition to the model of care. And then this loss to follow-up concept, which it's just so frightening for me. You know, I'm a nurse by trade, and you know, having to know that these kids may or may not ever get back into the system. Our special healthcare population here in Nashville, a lot of them do not speak English. They've immigrated into the United States. They're from other cultural backgrounds, and so we looked at you know, devising an outpatient case management model targeting this specific population. We looked at the data. We said, well, how are these patients using our system now? What are their families telling us? And we tracked their emergency visits. We tracked their primary care visits. We tracked their specialty care visits. We tracked their hospitalizations. We went into the system to try to find all that data by codes, by, you know, obviously, and that took a lot of time to do that, because again, when you're starting to look at the population, it's not just this nice bit, you know, piece of pie. You can easily ask your data folks to give you all that information. You really have to go in and pare it down. And through that process, we found that we weren't tracking them very well in a registry as a cohort. And so that was one of the biggest things that we did initially first. We put together a team. We have some process champions. Dr. Baron Patterson, many of you may know him here at Vanderbilt. Key advocate for this. Dr. Laney Davis, a physician champion on the team, working with us day after day after day. We set up process meetings so that we were all sitting in the room or we're doing virtual conversations. We started meeting, it started off weekly, went to every other week, and now monthly, and now we just kind of have a maintenance schedule now. But it takes a while to develop that. And we did address the leadership. I think that piece was really important. We did a summary of what the intent was and what the process was for the leadership at Children's, so that it wasn't a surprise and people knew what we were doing at the leadership level, the highest leadership level, and that was really helpful, especially when we went looking for some resourcing to help us out.
This is a unique model that was designed by Greta Fowinkel, the Director of Case Management and Utilization Review. You usually see case managers and utilization combined in hospitals. Greta had the great idea of separating these out so people could be more efficient in their work and spread this throughout the country as you go, because this is very helpful. And she also designed a discharge planner to help the case managers get their orders in a timely manner, get the supplies and everything. And then out of that came an outpatient case manager, and that's me. And this was the initial role in our institution, was an outpatient case manager. I've been in the role now, I'm in my 6th year, and it has been extremely helpful in bridging the gap between inpatient and outpatient. As many of you probably have experienced, when a patient is discharged, sometimes orders are not carried through to the outpatient setting, or maybe the appointments get lost in the shuffle. And so it's really helpful to have an outpatient case manager to coordinate all this. Also, an outpatient case manager in a nurse role or a social worker role has skill in with the medical needs and the plan of care. So I think that it's helpful to have someone with that background. Children with special health care needs, their parents have difficulty navigating the healthcare system. A case manager coordinating this care is helpful, not only with getting supplies and resources, but having the knowledge to be a liaison with the community and to network with the school nurses, home care. Wound care is always an issue. There's always many glitches with getting supplies. TennCare authorizations, it's helpful to have a point person there for the parents.
So the origins of this project really emerged back in 2009. Linda mentioned Dr. Greta Fowinkel as a doctoral project for her. She began that, and she's the one that looked into all the data with regard to the cost of the organization for not well managing this population and not understanding the trends in the care for this population. And so she did all the foundational work between 2009 and 2011 and really discovered kind of where those barriers were and began to really talk about that. I came to Vanderbilt in 2011 and for part of my doctoral work, continued with the recommendations from Greta's initial project. And really that was the piece of developing the algorithm, the policy, the tools, and the process. And what we found at Vanderbilt, in any system, I mean, everyone, the provider team, the nurses, the case managers, everybody's busy seeing patients. And what they really needed was an administrative type, like me, to come in and help with process, to keep the process going, develop some tools, actually write them down, look into the literature, ensure that we were making right choices based on the literature, and keeping the team process moving. And so that's what I tried to do in my doctoral work, to continue this case management model, but more formalize it for the organization. And so we did that, and we are continuing to do that as it evolves, and we revise things all the time. So we use the theoretical model for medical home. This is out there in the literature. You have our slides. We recommend that if you're interested in the theoretical basis for the medical home model, here's this. I love that it has the circles and the arrows indicating kind of, you know, the integration of these pieces of the model in order to provide a robust medical home. I think we use that term medical home kind of loosely now, and it's up to a lot of interpretation the way medical home is interpreted. But if you go back to a model and you try to put some of those pieces together in your practices, then it's sort of at least helpful. You have some sort of basis for it. And this also, I guess, it's adaptable, and that's what I also love about some of this. The model can be adaptable to whatever size or shape or flavor you have in your practice. But we did use this one. And then we talked about this in the last hour. I'm not going to revisit these conversations or the definitions, but understanding what medical home is, having folks who are working in the practice understand what medical home is really an important concept to this. And then what is transition care and what is transition practices. And we'll say this probably 10 times in this presentation. Providers are I call them, they're kind of armies of one, but you have a team, hopefully somebody around you. Some of you have small practices, some of you have medium size, some of you may have large size, but the nurses and the support staff are essential. They're integrating and talking and communicating with the patients, as much if not more than sometimes the provider encounter. And so we optimize the use of our telephone call center, our nurses who are doing that, educating them. At our system, of course, we've got everything from staff and attending to our interns and residents that are rotating annually. We have nurses, we have nursing students, we have case managers, we have nurse practitioners. We have a lot of team to be able to educate, but trying to leverage as many of them as possible in the process was important for us. It's a team effort, and I'm sure Linda will say that at least 3 more times. Maybe 10 more times. Again, we talked about the transition care and the definition for that. We defined that for the organization. And, just to say, hey, it's an appropriate care. It's a movement to the system. I love the fact that Dr. Cooley said that, the patient's moving along in their life transitions, whether we acknowledge it or not. I mean, and it's not us transitioning. It's the patient and the family transitioning. And their life needs change as they grow from a 12-year-old to an 18-year-old to a 24-year-old. And recognizing that was, I have to say, it was a bit of a struggle for some of the folks. But yeah, you keep talking about it enough and enough, and finally people start to listen. And here's the process, a structured approach, fully agree with that concept, having it written down, having it posted, having it educated annually, not only in the healthcare team processes, but also with the patients and the families. We want to maximize lifelong functioning. We are finding more and more of these kiddos are living longer in more robust lifestyles, and their families are becoming a little bit more savvy about what they can and can't get in the healthcare system. And then those great organizations like the Family Voices and those things are cropping up here in Tennessee as they are in all states. And, you know, they're getting the word out. The schools are actively involved as well in a lot of this. So that was really helpful. Our families, they can ask some pretty pointed questions, and they want to know, you know, how come? When we started to talk to some of our appointed families, we selected families, they didn't want to leave their pediatric provider. They love their pediatric provider. They loved Vanderbilt. They don't want to leave Vanderbilt. And so it was a big deal for them. And we know it's the right thing to do.
Well, this is my model. This is my map. First of all, we identified the 18-year-olds from our 300-plus registry of complex children in our clinic. And then we collaborated with the resident and the attendings to make sure that they felt that those 18-year-olds were appropriate for a transition. We wanted to get their permission. We scheduled visits with the 18-year-olds and their families in the well child visit, not when they were sick. We didn't want to introduce this to them when they were stressed out from being sick. And we we explained to the parents the benefits of transitioning to an adult provider and the reason for that. And then one of the things that seemed to be the best carrot was the tour of the facility. And I said, I will go over, I will meet you at Vine Hill, and that's our facility that we're using for transition. And we can tour the facility, and I'll meet you there, and we'll meet the staff. And then the other thing is that we followed up with them after their visit. And I stayed there the whole time. I went on the tour. We saw all the exam rooms. We saw that they had dentistry. That was a big attraction, that they have a lot of Spanish-speaking staff, and that was very helpful. And then we followed up. And I can't emphasize enough that this is a team effort. It involves the planning, the structure that we've all talked about, having everybody in the clinic involved. We have about 60 residents in our clinic, and so you have to keep this on the forefront of everybody's mind. And it's not just about a case manager or somebody dedicated, because when something happens and that person leaves, if you only have a handful of people involved, or if the case manager gets so busy that she can't keep her finger on everybody's pulse, it goes away. It just drops off of everybody's radar. And so, and any project manager will tell you that you can go to all these means to start a project, but if you can't sustain it, you've just wasted your time and your effort. And this was reinforced by a webinar that I saw recently from the New York Mid-Atlantic Consortium, and Dr. Peter Gillette, who had an internal medicine clinic and also hematology clinic. He said he had a great program for his sickle cell patients when he had a social work navigator. But there again, when that navigator left or became too busy, his program fell apart. I want to give a plug for this NYMAC consortium. There's one more webinar on May the 6th, and it's going to be a panel discussion of parents. There are other webinars, the previous webinars you have access to, their slides and their recorded presentations, but it was very useful. So this was our process. As I said, we identified all the 18-year-olds. We started out just putting this registry together according to ICD-9 codes, but then we found that there were some flaws in there. And so Lainey Davis, Dr. Lainey Davis, developed a screening tool to provide more accurate results. And then we identified those that were past due or coming due between the ages of 12 and actually 20. We started out with meetings with the Vine Hill staff and leaders, and we had many meetings before we ever transitioned our first patient. As Kelly said, it's a federally qualified health center. I'm sure they've obtained their certification by now for medical home. All the providers are med-peds, family practice trained. And one of the great things is that they have access to our electronic medical record, which is Star Panel. So they're able to see the child from NICU to adulthood in that Star Panel, which is very, very helpful. They also have dedicated insurance and social service coordinators, culturally sensitive, and their hours, they have a 24-hour triage evening and Saturday. And one of the best things the parents love were the easy parking. You know, they didn't have to go to some garage. You can drive right up to the door and get your child in.
Thanks. So this is the initial letter that we developed as a tool that we printed out on nice Children's Hospital paper. It was in color and in multiple languages, well, 2 languages, Spanish and English, that we began to circulate to patients and families to start talking about this process and what does it mean and what did we value with regard to transition. Not as a shocking kind of thing, but just as starting to get the awareness. Vanderbilt decided that the process would begin at age 12 per the recommended national standards, and that 19 was the age, by the age 19, in which transition would effectively take place. That's what Vanderbilt, the providers, the team felt comfortable doing, and so that's what we wrote in our algorithm. That's what we wrote in our policy. And so it worked. Now, we did have patients that were a little older than that were the providers wanted to hang on to them, and that is okay. And we still have providers that have this bond with the patient, and they don't want them to go through the transition process. We work very closely with each individual provider when we identify someone who's ready to go. But starting the cohort at 18 really was a big deal. Now we know the 17-year-olds. Now we know the 16-year-olds. Now we know the 15-year-olds. So we can begin to do that a little bit more formally. And when we're talking to the resident class or we're talking to any new employees that are coming in that are navigating or welcoming patients, they're starting to get to know this. We did use the Well Child, the checkup schedule. And that helped us as well ensure that it wasn't a shock to them. It was more of a conversation with families and patients. Here's our algorithm. We adapted the algorithm that Dr. Cooley referred to in the first hour this morning. We just adapted it for the purposes at Vanderbilt, and it worked just fine. You can take it right out of the literature and put your own words in it, but we followed it fairly closely. Each of these sections that are outlined on the slide here had a narrative that went along with it. So not only was it a visual cue, there was a narrative to explain it further. That really helps when you have a student population in medicine. You know, we're trying to educate our future generations of providers and nurses, and they needed that. And this was an internal tool that we shared internal to the organization. We educated our patients and our families. I talked about the multiple languages. I made a visit over to the marketing folks. I know not all of you have a marketing department. Children's Hospital, fortunately, does have one. But they're not made of gold over there. But they did have some end-of-year monies a couple of years ago. That I went over and I just said, hey, this is what we would like to do. I had designed a template. Could you maybe put it in the children's logo, put the official, and they said, we've got a little bit of money here, and not only are we going to do that, the handouts, but we're going to make some poster size for the clinic so that they can put them up on the walls. And we talked about the whole Joint Commission thing where you can't just stick posters anywhere, but behind the glass cases, where the patients were sitting in the waiting areas, in all the exam rooms, we were putting these symbols up, talking about and I'll show you, here's one of them. And they were using the children's colors and the color scheme. So it was very familiar and part of I think it also demonstrated ownership, that, children's owned this process, and they were really putting their money behind what they said. So a little bit about what medical home is, and a little bit about what transition care was. We also updated our website. Not that every patient and their family, or families in our case with our special needs population, are going to be on the website, but others may be. And those, because we kept saying, while we're focusing right now on our special needs population, all kids who turn at the age of maturity need to go on to transition. So we defined it. We put it on the website. We worked with the web folks, and we just defined it, put it out there. So it's a resource on the pediatric primary care clinic website as well. So we did do the handouts as well. Here's one of the handouts that we developed. This went through a lot of iterations of not only the team working on it, the providers were comfortable with it, but we ran it through our education folks at the organization to ensure that it was understandable by the population, at a kind of a health literacy review, and it was acceptable for them. And they said, yep, this would work. And we put this in Spanish as well. So that this tool is in there, and we're happy to send all of these to you. I showed you these. These were some of the signs, postages that we put up, and they were really nice in all the exam rooms and in the waiting areas. The other piece that we did, for those of you, and I'm not sure where everyone's origin is, but if you're working with students, medical students, nursing students, and they have their own sort of internal electronic system in which they're doing communication, we posted it on what we call an intranet so that the residents could see it, and it was in their didactic training program, so that they could go in, and we made it so it was part of what they were going to get as part of their education annually. And it's up to us to update that and refresh it annually, but at least we know it's going to get into their as we talked about earlier, there's so much that we're trying to educate our young providers and nurses with these days, but we've got to get these concepts in there. So we did our best to do a didactic. And that was really a partnership with the attendings and to our physician champion, Dr. Lainey Davis. But we went and did those. So Linda and I and Dr. Davis, we went to the didactics. We interacted with the residents for this. So I'm going to turn it back over to Linda.
Okay, this underscores the need for structure and planning. What didn't work is the result of not having the structure and planning, but we were in our infancy, and these were our first tries. We had 2 children to transition. Both were Arabic speaking. Father of one spoke English. That the first patient is a very frail child with cerebral palsy. Parents did not speak English. 2 siblings, adult siblings, did. It was kind of sad because I suggested that they go to a primary care residency provider, a local medical center, and I called them. I talked to them in their actually sick visit, and I drove the route to the facility so that I would know the most direct route. I sent them a map. I scheduled the appointment. Checked with them before and everything that I could do that I thought I could do. And they missed the appointment because they couldn't find Mahari. Okay. So we rescheduled the appointment. I talked to the English-speaking siblings again. They were sure that they were going to make it, but they didn't make the appointment. And we lost them to follow-up. I couldn't find them after that. I don't know what happened to them. And then the other child, the father was really on top of his care. And I asked a TennCare case manager for referral information. And we referred him to a physician in his local community, which was outside of Nashville. And he attended that appointment, but then he began to have pneumonias, recurrent pneumonias. and he began to use more of the Vanderbilt system, the ED, the hospital, and he died of pneumonia. I'm not sure. I don't think he ever really followed up again with his initial adult provider. But here's what did work. We started those meetings with Vine Hill, and this is a picture of Vine Hill. It's very friendly. It doesn't look like a hospital, you know, it doesn't look like a large medical center. The parents really like that, okay? So we started meeting with the Vine Hill providers and started this program. Here are our success stories. We have a 2019, 18, 21, 18, 18. Cher is was a 20-year-old who did not speak English. His parents are Kurdish. I had started a relationship with them, trying to get PT for him because he had limb pain in one of his legs, and his mother was a really dedicated caregiver for him. So he was our first one, and we transitioned him to Vine Hill, and everything was great. He had two older siblings too who also speak English. Well, then unfortunately, after that, he fell in the bathtub and hurt his other leg, and then he had some urology problems, and then he became more involved with the Vanderbilt Medical Center rather than going back. But here's the thing, because I have access to Star Panel, I could follow up that way, and with them, and then I also contacted the Vine Hill, and they reached out to him and got him pulled back into the adult provider setting, the PCP setting. Brian's mom was a little bit apprehensive about transitioning him because he had chronic decubitus, in a wheelchair, very frail, beautiful face, very more intellectually advanced than most children with cerebral palsy. But when she found out that she could still keep her plastic surgery provider, she was okay with it. We went to the clinic, we toured the clinic, and she loved it. Andrew was adopted when he was a baby. He has Down syndrome. He very friendly guy, never meets a stranger. He loved the clinic. He was very involved in making the decision. Paola was a cerebral palsy child in a wheelchair. Her mother did not speak English. She had an adult sibling who does speak English, and we transitioned her. Odie was sort of an unusual case. His grandmother is the custodian for him and has been since he was an infant because his parents died in a car crash, and so she had taken care of Odie for all of his life. And she tried to do transitioning on her own, and she explained to me that she walked into this appointment in a medical center clinic, and she was carrying him, and even though he was 18, he had the body of like a 7-year-old. And so she's carrying him in, and she thought this was a very traumatic experience for her. They're like, "Why are you carrying him? You know, why can't he walk?" I mean, so she was really happy to have a structured transition, and she loved the clinic. And all of these have made appointments and are followed now by the clinic. Omar is one that we transitioned, and this is a point to make. The father speaks English. The mother is Hispanic, does not speak English. She did not come to the well visits. And we explained everything to him about transitioning to adult provider and the reason and everything. And Dad was really excited about it. I went and met them at the tour. We went all around. She was really happy that they were bilingual. But then I should not have left because I didn't hear what insurance and all of this information that was being given to her. And apparently, she did not understand that she had to change her PCP. So they're still in the process of trying to decide on an adult provider. A win recently, though, is a mom called me and said, we talked to you last year about when Deontay becomes 18, we need to transition. And she says, I'm calling to transition. I thought, this is a win. Again, the advantages that we have is this electronic record continuity with this clinic. They take Medicaid, Medicare, the uninsured. We have provider-to-provider contact. So we were in all these meetings with the staff before we started this. So it's a really easy handoff. And then case management follow-up. And then the patients really like that they can continue to see their specialists and that their specialist records are all in Star Panel, all in the same electronic record. One of the things that we have done to improve our transition process is the residents created a QI group, and they created a template for, but what they were actually trying to do was create a template for their well child visits for their EPSDT. So we added transition to that template so that when they're preparing, they can be aware that this child needs to have some transition training at the time of those well visits. And we have a program coordinator who looks at the panel, identifies who is coming for an appointment that is 12 to 18 years of age, and notifies me and notifies the resident so that the resident and I can get together before the actual appointment and know what we're going to say and how we're going to talk to them. And then again, I meet with the family, and the tour is a huge success. The things that we have learned is, from the initial effort, is we need to have a structured handoff, and even now our handoff is not exactly what it should be. We're using the patient summary in Star Panel and keeping that updated, but most of the handoff is done is verbal, just like you're calling an ED report, you know. One of the other things is that the patients, many of our patients, in fact, all of the patients on my panel are TennCare patients, and parents can get free transportation through TennCare, and sometimes that's their only means of getting to Vanderbilt. And so they need to know how to make that transportation call to TennCare's umbrella of vans. Because I've been doing it for some of those that don't speak English, but when they leave, I'm not doing it. So they need to know how to do it themselves. They also need to know who their providers are, because if they don't have a case manager that's looking into their supplies or someone they can call directly, they need to know how to pursue this themselves. Again, this is a collaborative effort of planning and communication, and I just want to reinforce how important relationships and building relationships with the families and with and networking with the providers and the suppliers and the school nurse and everybody. It's very important. So our next steps is we have two 18-year-olds now, one of which has already called me, 5 17-year-olds, 12 16-year-olds, 6 15-year-olds, 10 14, 12 who are 13, and 13 12-year-olds. So we are continuing to identify these families and meet them on their well visits or their continuity follow-up visits. The next steps I think we need to take is I would like to start an annual didactic for the residents, especially since every July we have new residents coming to Vanderbilt. And we have not, we are needing to do a better job of a readiness evaluation. We want to improve our handoff tool and survey the experience that patients and families have had as they transition. And, you know, when you have a project going, you always have to reevaluate what you're doing. You just can't keep doing the same thing. And we had a parent advisory group, but that has sort of dissipated, and so we're going to reestablish that. This is very important, and you're going to hear all the details of this in the afternoon sessions. Parents do not have much information about special needs wills and conservatorships. And so if you can stay for the afternoon session, I think you will find it worthwhile. Also, we need to prepare patients for the insurance changes that will happen when they reach 18. These are just some of our references. And, you know, again, this is an effort to maximize the lifelong functioning of these young adults, which are such a vulnerable population.